Hey nurses, looking for exclusive discounts? Nurse.org has you covered with deals on everything. Save big on the essentials you need to excel in your career. Don't miss out. Visit nurse.org/discounts for the latest discounts made just for you. You're listening to Nurse Converse, presented by Nurse.org, a collaborative podcast amplifying diverse nurse voices. Get ready for a dose of inspiration, a sprinkle of education, and a whole lot of community.
Hello there. My name is Courtney. I am a nurse practitioner, and I want to talk a little bit today about death and dying, working as a hospice nurse, and, just working as a nurse in general. So I want to start talking a little bit about my experience and kind of what draws me to talking about this topic today. So I started my career as a new nurse in oncology. It was a wonderful place to start my career. I'm so thankful for that job. And we kind of got a mix of med surg, oncology, and we got all of the end of life patients that would come from the ICU when they needed to get rid of that bed, or from the ER, or from other floors. And while working that job, I kind of was dubbed the angel of death because I would gravitate towards these patients. I would almost feel territorial over these patients. I wanted to work with them and their families so badly. And I really fell in love with hospice. But on the other side of that, I loved the thrill of running a code or working with critically ill patients. So when we moved to a new city and I needed to find another job, I decided, hey, I'm going to go work in the ICU and fulfill this dream. Well, very quickly, I realized that acute care was not an area that I was thriving in. There was some toxicity amongst the floor, some cliques, and then attention to detail required that I did not quite possess. However, while working in the ICU, I continued to feel so drawn to end-of-life patients, to patients that were being extubated and weren't going to make it the rest of the day, or families that were on the fence of signing a DNR. All of those patients I felt so drawn to. So when I realized that I was absolutely miserable in the ICU, I decided to branch out and look into hospice nursing. But the kicker is that I had absolutely no idea what a hospice nurse did. So I texted my mother-in-law and said, hey, do you know any hospice nurses? And she said, yep. She put me in touch with someone, and that person said, hey, let's do a meet and greet. Well, I walked in and turns out it was an interview. So I did the thing that I recommend all nurses to do, which is I said, hey, I need to shadow this unit, so to speak, before I sign up for a job. So I did. I went to a local nursing home with a hospice nurse, and I fell in love. I thought, oh my gosh, I can't believe I'm going to get paid to do this for work. Signed up to be a hospice nurse and worked as a hospice nurse for the next 4 years until I became a nurse practitioner. So end of life is the area that I am absolutely passionate about. And the kicker is that in healthcare and in all areas of nursing, you can absolutely be subject to dealing with end of life, whether you're in labor and delivery, whether you're in the ER. Even if you work in outpatient, you could build a relationship with a patient and then find out at their next appointment that they're not making it because they passed away, which is why end of life is such an important discussion to have amongst healthcare workers and amongst nurses. So I want to talk a little bit about dealing with death as a healthcare provider. I think we always say and we know to prioritize self-care, but it's much easier said than done. So I want to talk a little bit about the ways you can prioritize self-care. The first one, I think, starting with is setting boundaries, and that can be setting boundaries with coworkers, setting boundaries with your place of employment, and setting boundaries with patients. One of the things I struggled with when I was working as a hospice nurse was bringing home work with me, because these were my patients and I felt responsible for them 24/7, despite not being on the clock 24/7. So if your patient has a fall or something like that, even if you're not the one on call, it still felt like my responsibility to some degree. And that was really hard. So I had to work very hard to set boundaries of putting my phone down, not logging in after work, not looking at it, as well as communicating my needs with our place of employment. Another thing I recommend when dealing with death and dying in patients is talking to people outside of the healthcare arena. As healthcare workers and as nurses, I think we get very used to compartmentalizing our trauma and almost kind of wearing our trauma on our sleeve. The term bag 'em and tag 'em is very commonly said, And when we're, on the floor working our shift, it's very normal to brush off death and walk into the next room, even if it is affecting us. So I highly recommend taking a moment at the end of your shift or the next day, doing journaling, reflecting on how did that death affect me, instead of trying to push it down to a place where it's non-existent and bundles up. I think talking to people outside of the healthcare arena can be really beneficial for that. People outside of the healthcare world tend to react in an, oh my gosh, how did you deal with that type way, versus in the healthcare arena, it's almost kind of trumping your story of, oh yeah, I had a patient one time that XYZ. And that can be very toxic. So realizing it's okay to experience those emotions. Speaking of experiencing those emotions, it's also okay to experience a wide variety of emotion. Being joy, for instance. When I was a hospice nurse, there were so many times I worked with patients who were ready to die. I had one patient who was over 100 years old, and every time I would see him, he would say, Courtney, when am I going to die? And I would say, oh, not today, I don't think, because he wanted to go home. We have patients that are happy to see their loved ones again, potentially, who are happy to be free from pain, to not be confined in bed. And so, in fact, the vast majority of my emotion felt in hospice nursing was not sadness, it was joy. So feeling anger when we took care of pediatric patients, and there's nothing you can say to the family to make them feel better. There's nothing to be said. Feeling that entire spectrum of emotions is completely valid and it's completely allowed, and you're allowed to feel a mix of those emotions. Another thing I want to touch on is the words rather, death, dying, and dead are not bad words. In healthcare, when talking directly to families, I think we often try to say that person is passing away or that person is getting closer. We try to add a little bit of fluff to those words, skirting around saying the actual thing that's happening, whether that being this person is in the active dying process or that patient did die at this certain time. I think we need to get used to being comfortable saying those terms to ourselves and to our family members and to the patients themselves, and having those conversations, those transparent conversations. One of the things that comforted me when working with dying patients, and a phrase that I always explain to myself and explain to others when asked about hospice nursing, is I may not have been able to control their disease process, their dying process, their dying timeline, but the one thing that I definitely had control over working in hospice, working as a nurse, is their comfort level as they pass. And that is so true. Working closely with death, I was able to advocate for specific medications, specific doses, certain equipment, certain frequency of visits, advocate for the patient to be seen by a chaplain or a social worker. I was able to advocate for a wide variety of things. I was able to love and hold their family members after they died, visit them at their funeral, assure them that this person was comfortable when they passed, this person was ready to go. For instance, if a dying patient wants to pass away when the family member is not at the bedside, they will find the 30 seconds that that family member goes to the bathroom to die. And that can be very hard for families. They're like, I didn't want to not be with them when they died. So working as a hospice nurse, you can assure them, or working as any nurse, you can assure them that their loved one had everything they needed in the end, that this person did everything that they needed to do to care for that person. So you're there just as much for the families as you are for the patients. And you're honoring their wishes at the end of the day. So I think it's important to remind yourself that I couldn't control that patient's cancer. I couldn't control that patient's ALS. I couldn't control any of that. But what I can do is make sure that they're breathing at a comfortable 12 breaths per minute respiratory rate versus 50 per minute. Those are things that I can control, working with long-term care staff, working with families, doing education on how often to give medications, because you're not there in the home 24/7 with them. It's the family providing care at the end of the day. Those are all things that you can implement to bring your patient comfort and bring yourself comfort, knowing that even though you're not treating the diagnosis, you are still doing things.
Enjoying this episode? We want to hear from you. Share your feedback and support your favorite host by completing a quick survey, and you'll be entered for a chance to win a $50 Amazon gift card. Head over to nurse.org/podcast and let us know what you think.
Speaking of some of the more technical sides of dealing with end of life and death, when it comes to talking to families, I highly recommend talking in a specific tone of voice, similar to the one that I'm using now. A low tone, low inflection tone of voice, maintaining lots of eye contact, and sounding very confident is very important when talking to end of life patients, talking to their families. I hate to say fake it till you make it, but reassurance is very important when talking to these families. So, talking and coming in with this reassuring, calm, confident tone of voice can make a huge difference. Oftentimes, when I would go do hospice admissions, this patient and their family had just gotten home from the hospital. They have no idea what they're walking into. Sometimes they don't even know or realize what hospice is, what we're going to do, and what we're going to provide. And with that being said, coming in with this confidence, cool as a cucumber, hey, I have got you taken care of. This is the pinnacle of where we're going to be at, and it is all easy peasy from here, can be very helpful for patients and very reassuring. And with that comes, I think, preparing the room. When I would have patients transferred from the ICU into an end of life room, preparing the room is one thing that you can do. Turning down the lights, getting rid of vital sign equipment, getting a snack cart there for the family. All of those sorts of things can kind of prepare the atmosphere of calm, cool, collected when you're dealing with an end of life patient. To wrap up, I kind of just want to talk about some really cool stories about death and dying that really kind of make me who I am and that really stick in my brain. And I want to tell these stories because I think they tie into different atmospheres. So, the first one being the first time I got a Daisy Award, I had an end of life patient on the oncology floor, and her granddaughter was visiting her, and her granddaughter's children were with her. So I was caring for that patient through a 12-hour shift, and I asked the mom, is it okay for the kids to have apple juice and crackers? And she said yes, so I brought them apple juice and crackers. And she wrote me a Daisy Award nomination based on that simple act, because I was giving her child an activity to do so that they were distracted, so that this granddaughter could spend actual quality moments focusing on her grandmother and sharing those moments. That was such an important thing to her. So little things like that, no matter how small, can play such a vital, important role in someone's life, their actual life. Another interesting story I have that kind of speaks to the idea that when a patient is ready to go, they are going to go is I was working as a hospice nurse, and I went to one of my assisted living facilities to talk to and do my visit on a patient there. He had pretty severe dementia and had been in a little bit of a transitioning phase where he was sleeping more often and eating a lot less and having more confusion over the last month. And I did my visit with him, and he was very anxious, very abnormally anxious, almost bewildered. So I talked to the nursing staff there, and we decided we were going to give him his PRN dose of Xanax. Well, I wrapped up my visit with him. They gave him his Xanax, and I went to the memory care unit, which was right next door, and I got a call saying, hey, can you come back and see this patient? He has had a total change in condition within the last 15 minutes. So I go over, I'm assessing him, and he is all of a sudden actively dying, lethargic, will not wake up, comatose, breathing, slow respirations, all the things. So I call the family and I say, hey, what we've talked about is kind of happening. I think that if you want to come here, now is the time. So family shows up, his daughter shows up first, his son shows up next, and I was there with them talking about, the events that had happened, where we were at now, how this made sense because he was probably in a fight or flight state, and then we gave him his Xanax and his body and mind were actually able to relax to the place of spirituality and where his body and everything was actually ready to start the dying process. So family was there, and as soon as his third and youngest son walked in the building, not even in the room, but into the building, walked in, the patient shot up out of bed, sat up, looked around and said, "What are we all doing here?" And they all looked at him and looked at me like, "Is this normal? What's going on?" He sat up and talked to them for the next 4 hours. Had wonderful conversations about life, about death, about his wife who had passed away previously. And they all looked at me like, "Well, there's no way he's dying, right?" And I looked at them and I said, "I still think that he is going to pass away today." I think that this patient did not want his family or his youngest son to see him in that way or to remember him in that way. So sure enough, around 6 o'clock that night, they all packed up. They all said, "Okay, good night, Dad. We'll see you tomorrow. Love you," said their goodbyes. And I prepared them that this was still probably the final goodbye. Sure enough, we got a call at 8 o'clock that night that he passed away. And so that, I think, just kind of speaks to the amazing and odd things that can happen in that end of life. I also had a patient who his wife was with him 24/7. She had to step out to find her credit card information to book a flight for her son. So she stepped out to book that flight, was only gone for maybe 15 minutes, and in those 15 minutes, he passed away. And this was really hard for her because she felt like she left him alone in his time of need, and I had to assure her that no, you were there in all the right times. He did not want you to see him that way or remember him like that, so he chose to pass away in those moments when you were not there. And all of that's to say the importance that we have as nurses on the front line of death can have, no matter what setting you're in, no matter what your shift is like, those little moments can absolutely make or break it for a patient. So I want to wrap up by just reminding you as nurses, as healthcare workers, to take time to prioritize yourself, to feel the joy in death, that it is not all bad, to feel the control that you have with patients and with families and the differences that you can make. Recapping all of this, it just brings a smile to my face in all of the lives that I've been able to touch and all of the patients that have touched me. It truly makes me tear up to think about some of the patients that I have and that I've cared for. And while I'm saying that, I'm going to remember to touch base with myself and how I'm feeling about those things and allow myself to feel all of that, because there's no shame in any of the joy or grief that I'm feeling. So if you're interested in more about technicalities of death, such as vital signs, what to expect, more about being a hospice nurse and what that transition looked like for me, feel free to reach out to me or follow me on socials at court.nurse on Instagram and on TikTok. I have lots of content there. So thank you for spending this time with me, and I wish you the best rest of your day.
Thanks for joining Nurse Converse, brought to you by Nurse.org. Help us grow by leaving a 5-star rating and review on your favorite podcast platform. Nurse.org supports nurses with career and education tips, life advice, and breaking news. Thank you for all you do and for being you.